Good morning, everyone. It is 10:16, so we're already a minute behind. We're going to go ahead and get started. If everyone can please take their seats. Well, thank you all so much for being here. It's the last day of the conference. It's already here. My name is Olivia Dieni. I am with the Cystic Fibrosis Foundation's Health System Innovation and Navigation team, and I really want to thank you all for taking the time to be here at this important session, and thank you to those of you who are online and taking time out of your Saturday.
And I'm Ryan Perkins. I'm an adult and pediatric pulmonologist at Boston Children's and Brigham and Women's Hospital, and also a health services researcher. Thank you all for sticking around for this session. We're excited you're here.
A disclaimer. Here are disclosures. I am CFF staff. So this session is a very, very important one. And at this conference, we've had so many amazing presentations on new innovations and changes in the care model. But none of this matters if people cannot access it and if they cannot access it affordably. And really, before kicking it off and going into our session objectives, I want to share this slide, which you may have seen at other sessions at the conference. Everything in this session relates to health equity, or sometimes health inequities and disparities that can prevent some people with CF from accessing their care. So this is a summary of some of the health equity work the foundation has been doing, and if you scan the QR code, you can get more information on these resources. So these are the objectives for today's session. We have a very, very tight schedule, so we are going to keep it really close with our presentations. But our presenters will be spending some time discussing what cost and coverage looks like in the United States today, how care centers can be involved in advocacy and access efforts, discuss the impacts of the changing care model on cost and access, share a bit more about what the future could hold with genetic therapies, and finally close with a very important discussion on access to high-quality care internationally. A few housekeeping items. Each speaker will have just a couple minutes after their presentation for questions. Again, if we do not get your question answered, you're welcome to submit them through the app or come up to the podiums and the microphones. Again, this is live streamed, so we ask that you please go to the microphones if you do have a question and want to ask it in person. We will also hopefully have time for a panel at the end, but if we don't have time and we run out of time after the presentations, our speakers will hang around for a couple minutes to ask any of those questions. And with that, we are pleased to introduce our first speaker.
So we're very fortunate today to have Ann Willis coming to speak to us. Ann is a Senior Director of Health System Innovation and Navigation at the Cystic Fibrosis Foundation. Ms. Willis led the foundation's effort to understand and address social and economic and access barriers to care through increasing equitable access to health care, supporting care teams in addressing patient social risk factors, and helping people with CF and their families troubleshoot access, financial, and practical challenges. So today, Ann's going to speak to us about the current landscape for cost and coverage for CF care in the U.S.
Great. Thanks, Ryan and Olivia. So I am going to do a high-level overview of cost and coverage landscape, looking broadly across care and treatment for people with CF. I have no disclosures. So I'm going to start with cost. I'll shift into coverage. I'll talk a little bit about the policy landscape, and then I'll share some tools that care teams can use with your patients. But before we start, I think it's important to think about what do we mean when we say cost of care. There's a few different ways that we talk about cost of care. There's cost to the society, which includes things like lost productivity, economic contributions. Generally in the US, we are not talking about cost to society. We are often talking about health system costs. So these are the costs that companies, payers are paying for services, medications, hospitalizations. And then there's costs to individuals. And so these costs include direct insurance costs. So things like premiums, deductibles, copays, can also include indirect costs, so things like transportation to get to clinic and taking time off of work. And it's important to remember that health system costs do not always directly translate to individual costs, and that is because of health insurance. So the vast majority of people with CF in the US are covered by health insurance. And so they are not paying the entire totality of the costs that the payer is paying. And it's important to remember who we're talking about costs, and this is going to be important in the next presentation. And also the policy levers are different depending on what we're focusing on. That said, the costs do have downstream impacts for people with CF, and I'm going to talk about those more in a second. But let's start with cost to an individual. So when we talk about insurance, we often talk about insurance as if it's one thing. In addition to there being differences between public and private insurance and different types of public insurance, there are thousands of insurance plans across the country. Insurance companies, even in a single area or a single state, can offer many different options. And when people are trying to navigate those options, they may or may not have a lot of choices. Some people may be choosing from 2 employer plan options up to 70 marketplace options. And we certainly see this with people who have government insurance that have a lot of options that they have to go through. And we have started to see more people with CF who are enrolling in insurance outside of the open enrollment period. So they're having life events, so things like changing jobs. So they're not necessarily staying in the same insurance plan for long periods of time. And those plans can all be structured very differently. So there are differences in premiums, copay versus coinsurance, individual versus family plan, out-of-pocket max, is the deductible combined or separate? So the way the plan is structured has clear impacts on what an individual will have to pay, and then also how they use that plan will impact their costs. So what's the order that they're filling their medications? What services were provided? Who did they see? What did they get? Was there a facility fee? And because of the way insurance works, what you pay for any specific service can depend on what you've already paid for your insurance. So what is the cost to an individual? It's complicated. It depends on a lot of factors and can change from year to year. So cost does not necessarily equal cost burden. Earlier this year, we fielded the Cost CF study. We asked about a lot of insurance, financial issues, and one of the questions we asked was whether people had trouble paying for different components of their care. So here you can see people reported difficulty paying across a broad range of care needs. Some of that variation is probably due to insurance, some of it's due to copay assistance that's available for some of these things versus others. So that was the cost to the individual side. What are the downstream impacts of rising costs for people with CF? So there's a larger fight that's happening. The US healthcare market is showing signs that it can't bear the rising costs. There's a lot of focus particularly on medications, but across care. And so in response to rising costs, we are seeing payers implementing tactics to try and better manage their costs. Now, historically, over the last 10 years or 10 years ago, we would see a lot of these barriers put in place that had clinical issues, so things like step therapy. So this data is from 2023, from last year's data, and fewer than 10% of our COMPASS cases related to coverage and reimbursement were related to clinical issues. The most of the time that those barriers were in place, they were targeting drugs about 2/3 of the time. But we see that in the orange bar, and in the blue bar, those are tactics that are targeting other types of care. And so those include things that you are well aware of: prior authorization, reauthorization, not providing coverage for things that are not on the FDA-approved label, or not providing coverage. But what we see a lot more of are non-clinical barriers, and these are more evenly split between barriers related to medications and barriers related to other types of care. And so there's a long list of these: accumulators, maximizers, and alternative funding programs, formulary exclusions, admin burden, network limitations, terminating benefits, and then a lot of challenges with coordination of benefits. And this is very confusing for people. About 30% of our cases were questions, trying to understand, figure out what the barriers are, how people can prepare for them and navigate them. And then 6% were patients or caregivers who couldn't figure out the rules and needed help once they encountered a problem. The largest coverage barriers we see are in self-insured employer plans, which is not surprising. About 2/3 of the general population is enrolled in these plans. So these are plans where employers are taking on management of the healthcare costs. And so if they have a healthy employee population, then they might be able to manage those costs better. But when they have people with CF and other chronic diseases, those costs can be hard for them to control. And those plans are regulated differently than other types of insurance. And so they are able to carve out medications, and they also are not impacted by state copay accumulator bans. So we know that there's impact of from cost and coverage challenges. In the Cost CF study that we did earlier this year, about 36% delayed some aspect of their care, and so this could be delaying or missing medications. It could be not getting a test or service that was prescribed to them, and about 1/3 of the time, people reported that that's because of the cost of their copay, and about 1/3 of the time, it was the cost, or it was the coverage issues like prior authorizations and benefit verifications, and then the other ones were largely related to things like not being able to get time off of work. We know the cost of care requires trade-offs. 68% reported any financial challenge because of CF medical bills. So this includes things like not being able to save or tapping into retirement savings, so that money won't be there in the future when they need it. And it also can include things like working more jobs or working more hours. We also found that 27% reported some form of food insecurity. This number is actually better than when we asked in 2019, but it is still about double the national average. And if you can jump through the hoops, there is usually a path to access for the coverage barriers. So 97% of our Compass coverage and reimbursement cases last year ultimately resulted in people getting access to the service or treatment that they were looking for, but it is hard. 29% reported in the Cost CF survey that getting access to medications was challenging or very challenging. So there are lots of hoops. If people are able to jump through them, then they can get access. So because of that larger fight that's playing out, we've seen an increasing number of policies looking to address cost at both the state and the federal level. Our CF Foundation policy team is monitoring and weighing in on these policies, making sure that the experience of people with CF is at the center, and making sure that these policies preserve access for people with CF and don't place an undue burden on them. So on the state side, we've seen an increasing number of prescription drug affordability boards, which we will hear about in the next presentation. We've seen accumulator and maximizer bans popping up across the country. Right now, there are 21 states and DC that have these bans, though again, those self-funded employer plans are exempt from those bans. And we're seeing an increasing interest in prior authorization reform. So we have a couple of posters that I encourage you to check out to learn more about those. On the federal side, you've probably heard of pharmacy benefit managers or PBMs. There's a lot of efforts looking at their role. And then we're also looking at regulatory changes targeting alternative funding programs. So those are programs that are used by those self-funded employer plans. So it's very confusing, it's complicated. We do have some tools to support care teams and support your patients. These tools are available in the my.cff.org resource library. You can also scan this QR code, and there's a form if you say that you're interested in cost and insurance resources. We are happy to email those to you. And in the library, you can search for the name of the document that I will show on the slide. So from the Cost CF survey, the vast majority of people think that conversations about cost should be happening with their care teams. We know that these can be challenging conversations, So we recently updated the cost of CF care discussion aid to help care teams have those conversations in a non-judgmental way. And then also, I mentioned that stat that people with CF reported about twice the national average of food insecurity. We know that people across income spectrums can have challenges with costs and being able to afford basic life needs. So we have developed a social determinants of health toolkit, which has resources for care teams and also resources that you can give out to your patients. Care teams can also play a role in navigating coverage issues. We have a document on common issues with CF drug coverage and how to navigate those. We also do see network issues, which often get resolved, often at the very last minute, but can be very scary for people with CF and their families who are worried about maintaining their care. So we have a handout to help you navigate that process. And then one of the most important things we can do is make sure that people with CF are getting into insurance plans that can best meet their needs. CF Foundation Compass is here to help care teams directly or to work directly with patients. Right now, open enrollment is right around the corner, which is the time when many people have the opportunity to change insurance plans. So our team is ready to help people with questions, and we can help people find and compare different insurance options. And that way we can help people get ready for the next plan year. So in 2022, looking at the people who contacted us during open enrollment, only 1% of those people went on to call us back the next year about an access issue that we hadn't uncovered during open enrollment. So even if they are going to have a barrier, we can help them prepare for it so they don't get a surprise come January. And Compass is an important way that we hear from the community about what is happening. And so if you are seeing something that's new or something concerning, we encourage you to contact Compass to let us know, both so that we can try and triage in that moment with that particular case or issue, but also Compass directly feeds our policy and advocacy priorities. So once we see that there are issues happening, we can investigate and then see if there is an actual fix to that problem. So, speaking of policy and advocacy, I encourage everyone to take out your phone and text NACFC to 96387 to get on our list of advocacy alerts. We will not spam you. We will let you know when there are high priority issues. The care team voice is very important in our advocacy efforts, and we have seen some important wins over the last few years. And so we want to make sure that you know about those efforts and you can weigh in with your experience and your expertise. All right, I'm done.
All right, we have a few minutes for questions. So if you want to head up to one of the mics, you can also submit any questions through the app. And while people are thinking of questions, I can kick us off. Anne, you mentioned at the beginning of your presentation how many of these issues are administrative, and we know that prior auths are a part of that administrative barriers. Can you talk a little bit more about the policy levers related to prior auths?
Yeah, we've seen a huge increase in interest in this. There have been, I think, 35 bills at the state introduced just in the first half of the year. And so those are looking at a few different things. One is timeliness, so setting timelines for turnaround time for urgent and non-urgent requests. That's something we're very interested in. We've been advocating for 24 hours for urgent requests and 48 hours for non-urgent. Continuity of care is another area. So when a dose of a medication changes, for example, shouldn't need a new prior authorization for that. And also when someone changes the plan, that prior authorization should stay good for 90 days to at least 90 days to help make sure people make that transition and don't lose access. We've started to see some gold carding programs. So these are programs where prescribers who hit certain targets, which we've seen about 80 to 95% of PAs approved in the previous year, are exempt from PAs the next year. And then the other area is the sort of duration of prior authorizations. So we've been advocating for having a longer period of time for people with chronic disease. not having to do them constantly, trying to have a minimum of every year or potentially the duration that somebody is on a therapy, which would be super helpful.
And it's Greg Stoicki from Boston Children's. Thanks again for this overview and all the work that you and your team are doing. The question I have two actually. One is in terms of the requests you're getting and the maybe the things that you're seeing, is it largely related to pharmacy benefits, or is there actually a large percentage of plans that also are having problems with, accessing a CF accredited care center or healthcare utilization outside of pharmacy, or is the bulk of what you're seeing right now concerns around access related to pharmaceutical products?
It's both. So we do see a chunk. I don't know the total of it, but at least for the non-clinical barriers, it's about half of those are targeting medications, and then the other are targeting all of the other components of care, whether it's care center or services or tests or other things.
I just mentioned that because I think when families or an individual is looking at a plan, they may not always recognize that pharmacy benefits are a separate thing from other plan benefits, and it's often very confusing for, I think, our teams to even navigate that. I'm sure it is for you, but for an individual, very, very much so. And then my other question is sort of a philosophical question about what kind of advice you would give to care team members that they could then pass along to families if you are in a situation where you have no choice as a family because that is what you're given. It's an employer-sponsored plan. Do these families have any options, or is it that you're basically told, well, this is unfortunately the plan that you got to work with it as best you can? I'm not. I just wonder if you're not Medicaid eligible and you are essentially your employer says this is what you got, what can we really do?
Yeah, and so this is one where it depends on the particulars. I might ask Kelly actually to come up and speak to this, but there are certainly people who don't have options, and in that case, we really want to make sure that they're aware of all the different puzzle pieces. There might be assistance that they can tap into, other resources, but there are some creative workarounds that might open up some possibilities for people where it seems like they might not have them. Kelly, can you speak to that?
Yeah, so I would say that there are always options, but there are also going to be always trade-offs with that. So they would not necessarily be stuck in a plan that would completely give them no access to the things they need. But then if we are looking at those other options, there might be trade-offs in are they going to have to pay a higher premium? And looking at all of that kind of costs that go with that. So there are definitely options. It can definitely be frustrating for that family going through that.
And we've seen, we have some examples where, and this clearly depends on an individual's comfort level, where they go to their employer and can actually get an increase, a raise, to be able to use that money to go get a marketplace plan. So that potentially is an option for some. So there are some things that can be done. So it's not necessarily that there's no option.
We've also seen some employers who, having that conversation with the family who's explaining, this plan isn't set up to cover what I need, are actually able to go back to the plan and say, actually, you need to change this. You do need to cover what our employee needs.
While Mary is walking to the mic, and I think I know exactly the situation you might be alluding to. I think it's great to see you. When it comes to marketplace issues, it really depends on the situation, and it's something at the foundation when we do hear of it, our advocacy is around making sure there is a path to a person getting a network exception, or there's some path for people to have in-network care, because we do know that even if there is another care center, making sure someone can stay at their established care center, and also transportation challenges are real, and therefore it may not seem like a big difference or a big distance to travel. I mean, a state like Texas is very large, and so there are big gaps and big distances, but even some of the smaller states where there are multiple care centers, that transportation barrier can be real, and so making sure people have that path. Honestly, it depends, and I think each situation can vary in terms of the success in that advocacy. Thank you.
I think you pretty much just answered the question, Olivia. What I would say, the only thing I would add is for marketplace plans, it's infrequent that we're doing state by state advocacy for the particulars within their state. Most of our marketplace advocacy is really at the federal level and the rules and structures that are governing them, either congressionally or more often now in the regulatory front. So we spend a lot of time looking at things like the really hot New York Times bestseller of the Notice for Benefit and Payment Parameters. And actually we've had a lot of success in expanding and clarifying the rules that govern the marketplaces. And so I think that's really, to answer your question, where most of our advocacy lies, and what are the structures and the rules in place to ensure that a plan is covering what a patient needs, rather than the much more specificity of a network, for example. So we want the rules of how the network is established and what's required to define a strong network. That's where our advocacy sits. And then Olivia spoke to some of the specifics of how the network is actually playing out in a state.
And we have one question online. How might insurance needs affect the job mobility and career choices of people with CF? In particular, thinking about those who are young adults, who are entering the workforce, and then those who are approaching retirement, and any suggestions about how they can navigate these situations.
Yeah, that's a great question, and something we've studied previously. People have lots of concerns about insurance options, and so that might mean that they stay in a job longer than they otherwise would, which is sometimes called job lock. I think we're seeing things that might be changing a little bit if some people are feeling healthier, and so they might be a little bit more inclined to shift jobs. I think the most important thing is understanding the impact of health insurance and factoring that into any decision. Like, the specifics are so important, but being aware and learning and advocating, and Compass is always happy to help. We often review plans for people and try and help them get into the best coverage that we can.
Great, thank you so much, Anne.
Thanks.
All right, for our next speaker, Dr. Scott Sagal is a professor of pediatrics with a particular interest in children with genetic disorders of impaired mucus clearance, including CF and PCD. He serves as the CF Center Director at the Children's Hospital of Colorado, as well as the lead site investigator for the National Institute of Health-funded Genetic Disorders of Mucociliary Clearance Consortium. Dr. Sagal is Medical Director of the Pediatric Clinical Translational Research Center Core Laboratory at Children's Hospital of Colorado, which serves at the Center of Biochemical Markers, a CF Foundation-supported national resource center.
You can keep going. This is great.
That was a mouthful.
I feel better about myself. That's great. Thank you. Thank you to the symposium organizers for the invitation to speak at this session. As Anne introduced, states have begun establishing prescription drug affordability boards to assess and address the cost and affordability of prescription drugs. As of earlier this year, 11 states have established these boards. I'm going to be speaking about our experience in Colorado. I'll start by thanking our partners at the CF Foundation who helped us to navigate the complexities of the board. 3 members of the dream team are listed here: Leslie, Amanda, and Olivia. Maybe you recognize yourself on that slide. All right. And I'll also thank Mary Dwight for her support and consult. I have no relevant relationships to disclose related to this presentation. Lowering prescription drug prices has been a focus of the current administration and has been in the news quite a bit lately with the forthcoming election. One aspect of the Inflation Reduction Act is giving Medicare the power to negotiate drug prices. Last month, new negotiated prices for the first 10 prescription drugs selected for the negotiation program were announced. The negotiated prices, which will take effect in 2026, are expected to save billions of dollars for Medicare, which is funded by U.S. taxpayers. Depending on the next administration, it's possible that Medicare will negotiate prices for many more drugs. And similar approaches are taking place at the state level, and we're going to be reviewing what is happening in Colorado. In 2021, Colorado signed a bill into law that created a prescription drug affordability board charged with reviewing medication prices as well as setting a ceiling for some of these drug costs. And key aspects of the law is that the board is limited to setting maximum prices for up to 12 drugs a year for 3 years. And a review is triggered by any of the following. If a drug's price increases 10% within 1 year, for brand name drug costs that exceed $30,000 per year, and generic drug costs of $100 or more per month. This is copied from the Colorado Prescription Drug Affordability website, describing the board and the advisory council. And reading along with me, the Colorado Prescription Drug Affordability Board is a board within the Division of Insurance that has the authority to review prescription drug costs and evaluate their impact on Coloradans through affordability reviews of prescription drugs. The board may then recommend ways to address these costs and set an upper payment limit for prescription drugs. So I don't know about you, but when I look at this picture, it evokes feelings of tranquility and eternal bliss. We can rest well that the Prescription Drug Affordability Board is working for us Coloradans. But once I learned about the board and understood that it was reviewing a CF drug, I didn't rest so well. So really simultaneously, we were contacted by both our Children's Hospital Colorado policy and advocacy team as well as the CF Foundation's team. And this is verbiage from an email that was sent in June of last year. It reads, the Colorado Prescription Drug Affordability Board is considering setting a price, technically an upper payment limit on the drug Trikafta, lower than its current wholesale cost. While we agree with the state that many drug costs are dramatic and likely excessive, particularly for high-cost specialty drugs, we are also wary of the process of state-by-state price setting and have worried that if the state sets prices too low, it could cause drug manufacturers to cut back their offerings in Colorado. So Edith and I at Children's, Jerry, Jen, Mimi at the Adult CF program at National Jewish, we had a conversation with Mary and the CF Foundation's policy and advocacy team. So relatively quickly, we had to learn about this Prescription Drug Affordability Board. And this graphic, copied from the website, depicts the affordability review process that begins with identifying all eligible drugs that meet statutory criteria, I'll go over momentarily, selecting and prioritizing drugs for an affordability review, conducting an affordability review on the selected drugs, and then determining if the drug is unaffordable for Colorado consumers. Step 1, identification of eligible drugs was completed when the board approved the final list of prescription drugs eligible for affordability reviews on June 9th, 2023. During the initial review, over 600 drugs were reviewed by Colorado's Prescription Drug Affordability Board. Not surprisingly, all CFTR modulator therapies were on the prioritized list that the drug was reviewing. And this is a screenshot of the board's 2023 eligible drug dashboard. It was based on prescriptions in 2021. Now, maybe I should have enlarged it in some way. So what you can barely see is that Trikafta was second on the list of drugs prioritized for an affordability review. In terms of metrics, 372 patients utilized the drug in Colorado in 2021. The change in the wholesale acquisition cost, or WAC, was almost 5%. The patient out-of-pocket cost on average exceeded $1,700, and the total paid was over $75 million, which was truly an eye-opening amount of money for 372 patients in one state. Step 2 was selection of drugs for an affordability review, and this was completed when the board reviewed these 600, went through certain criteria, and determined which 5 they would actually proceed with a formal affordability review, and Trikafta was one of those drugs. This is an overview of the affordability review process and possible outcomes. The board was charged with determining whether a drug was unaffordable for Colorado consumers. If the board determines that the drug is unaffordable, they can decide as to whether to set an upper payment limit. The board is not required to establish an upper payment limit. It's one of the options. And an upper payment limit applies to all purchases of and payer reimbursements for a drug dispensed in the state. These were some of the factors that were included in the affordability review that included factors like the current wholesale acquisition cost, the cost and availability of therapeutic alternatives if they existed in Colorado, the relative financial effects of the drug on health, medical, and social services. And one of the factors included input from individuals with scientific or medical training. And so let's briefly review, the ways we engaged with the board and provided input. We participated in a series of 4 or 5 meetings, both public meetings with the board and individually with the board directors. The board accepted verbal and written public comments. We partnered with Mary, Leslie, Amanda, and Olivia on 2 formal letters to the board during the review process. One of the letters from a joint letter from the CF Foundation's policy and advocacy team, as well as the Colorado CF Center directors, is posted on the CF Foundation's website. Here are some of our key talking points when we engaged the board. We thanked the board for its work to increase transparency around healthcare costs and improve access to care for Coloradans. We explained that Trikafta is a transformative therapy with life-saving impact by reviewing key findings and critical clinical improvements from the clinical trials, the real-world effectiveness studies, the registry-based studies. We explained that CFTR modulator therapies are not interchangeable and there are no generic alternatives. We emphasized the orphan drug status. We stressed that any solutions to address rising prescription drug costs cannot come at the expense of access to care for people with CF. And we asked the question, how does the state plan to approach patient access challenges if the manufacturer refuses to comply with an upper payment limit? In addition to engaging the board during these public and private meetings, we also supported our patients and our families who were willing to speak with the media about the importance of maintaining access to Trikafta. These are headlines from our local newspaper and news stories that were featured on our local news channels. Just reading some of these headlines to you. A move to cut drug prices in Colorado has patients with rare diseases worried. Patients and doctors worry miracle drug Trikafta may no longer be available in Colorado amid possible price cap. Colorado is trying to cut prescription drug prices, but some patients fear they could lose access. So the report on the affordability review of Trikafta, the board's deliberation and vote summary was released on December 8th, 2023, and this is copied from the publicly available report. After deliberations and hearing public comment from 10 individuals, the board voted 5-0 that the use of Trikafta, consistent with the labeling approved by the FDA or with standard medical practice, is not unaffordable for Colorado consumers. I think that's awesome to just say it's not unaffordable. They didn't say it's affordable; it's not unaffordable. But I think the board, really had the foresight to recognize that this medication could truly be unaffordable if copay assistance decreases for these families. By saying that several board members emphasized their hope to hear from patients in the future if unaffordability problems develop, particularly due to patients' stated reliance on and fragility of patient assistance programs. So some members of the crowd, I suppose, went wild. I also like this headline from the Denver Post, that $200,000 a year CF medication deemed, quote, affordable by Colorado Review Board because of coupons. After this initial round of affordability boards earlier this year in 2024, the Colorado legislature negotiated compromise legislation to put new process protections in place around upper payment limit setting for rare disease drugs. For orphan and rare disease drugs, the Prescription Drug Affordability Board is now required to seek patient feedback and engage with patient advocacy groups and get input from a newly created Colorado Rare Disease Advisory Council. So just ending with some lessons learned in this process, certainly the vital role in partnering with and seeking the help of our CF Foundation's government affairs and advocacy team. We simultaneously partnered with our hospital policy and advocacy team to be active in the process, to participate in meetings, to provide input and expertise that clinicians are able to provide in this regard, to engage patients and families. Media can be used to raise attention, to support your cause. I also believe that efforts to make drugs more affordable may make more sense on a federal level or a national level, negotiating with the federal government, or maybe a larger state like California, maybe not quite Colorado. So I'm gonna end there. Thank you for the opportunity. Appreciate it.
Thank you. And we've got a couple of questions. Let's start over here on the right.
Good morning. You're going to have to forgive me because this is very personal for me. My name is Don Crease. I'm a cystic fibrosis dad. I've been a cystic fibrosis dad for about 22 years now. My daughter's name is Rose Keller. And Rose Keller was one of the very few people who had the courage to appear before the Colorado Prescription Drug Advisory Board and refused to go along with the idea that a drug that costs more than $300,000 a year is affordable. And neither my daughter nor I could live with ourselves if we did what people like you did, which is defend a price like that. I find it unconscionable, and I'm really sorry that my daughter was treated with such derision and hostility by people who disagreed with her about that. And so I think that there was a lot of fear driving what happened at the Colorado PDAB, fear that Vertex would follow through on its threat to basically withdraw Trikafta from Colorado if the state of Colorado didn't knuckle under the way it actually did. And so my question to you is, why didn't you just call Vertex's bluff and dare them to pull their drug out of Colorado here in the United States of America? Because I don't think they would have had the audacity to do that. That's
Thank
my
you
question.
for the comment.
Let's go over here.
Hi, Martha McKinney.
No.
I'm sorry.
No response. I believe in access and affordability, and that's what we argued for. Thank you.
Yeah, Martha McKinney, CHLA. I don't think I'm going to help soothe the waters any because I practiced in Canada for a number of years before coming back to the U.S. last year. And we actually did face a situation in Canada where we had the PMPRB, which is sort of the affordability group nationally for Canada, which looked at ETI and affordability and the other modulators and actually recommended not covering a couple of the modulators, and then finally did sort of say, well, okay, ETI would be coverable at about a 95% cost reduction, and Vertex actually did not submit the dossier for Health Canada approval for 2 years while we were waiting. So you can try to call Vertex's bluff. Canada kind of did, and Vertex said, well, then I guess we just can't submit our drug to your government if we're not going to, be able to, we can't lose money. So I guess my question was going to be that there is sort of a bit of a moral distress component to this, and you want that medication for your patients. You want that medication as a family member. You want that access, but you also want it to be affordable. And there is a question of how much you call their bluff. And we didn't have it for 2 years because of that, except for patients who are really in extreme distress. There was a compassionate access program, but you had to have an FEV1 of less than 40% and 6 exacerbations in a year, or an FEV1 of less than 30%. So for most patients who were not extremely ill, we didn't have access. So I don't know if there's a good answer. I guess that's my point. Is that it's just a horrible situation, I think, for all of us to be in. We did a lot of advocacy. It was effective. Coverage is pretty much, like in the US and Canada, it's state by state or province by province. But, it is a real situation, and I don't know what the right answer is.
Thank you for sharing your perspective. Appreciate it.
I will say I don't think we're going to have time to get to all of these questions. I want to make sure we can get to all of our speakers. We have one online and then maybe the 2 that are standing at the mics. And then again, our speakers will be available afterward to answer questions.
One of the online questions was, do most states have a PDAB? And if so, who are typically the members that comprise this board?
Yeah, again, earlier this year, there are 11 states that I'm aware of that have these prescription drug affordability boards. So it's a relatively new process. It's a good question in terms of who comprises, but in a sense, it was, in Colorado, it was under the Division of Insurance, and they reached out to particular members. I know that there are a couple physicians on the board, but I don't know necessarily the background of the other members. Thank you.
Hello, my name is Davina. I'm a mother of a child with cystic fibrosis, and I have the privilege of being to access Trikafta, and I take that privilege very seriously to recognize that there are people across the globe who can't. Any of us who were in the toxicity in CF Care yesterday heard that, in fact, Vertex would not lose money if they lowered their prices, and so to the point, and I'm Canadian, and so I did see the fight for access in Canada, and that was very hard for me to see how long that patients in Canada had to wait to get it after those of us in the United States had access, especially that being my home country, and seeing that and hearing that that was just with a request of 95, just dropping essentially 5%, if I was hearing that correctly, in price. I think that's actually outrageous that Vertex was not willing to make that adjustment in price so that Canadians could access it. And I appreciate what everyone in Canada did to continue to negotiate and get those drugs approved. I understand and recognize that this is a very nuanced topic, and we see it with how the NICE evaluated Trikafta last year, and that we saw a lot of people in the UK feel the same way and go after NICE for saying, wait, my child is not worth this price, even though they were saying, well, it's not necessarily that they're not worth that price. We just have a public healthcare system that we need to be able to offer medications to everyone. I guess actually my question, though, when I was doing this is, did we ever hear, I thought this case was so interesting, and I was really kind of excited to see what was going to happen with Colorado. And I thought maybe Colorado would stand their ground as well, and that we might actually see some things. But to your point, you had mentioned maybe a state like California may actually have a little bit more of a tug on this, or like on a federal level. But did we hear Vertex explicitly tell you guys that they would pull out of Colorado if they went forward with this? Or was it that we had an assumption or fear that that might happen?
Well, I don't engage, I don't work for Vertex, did not engage with Vertex, so I don't honestly know.
I just was wondering if we had heard them make any comment when they knew this was happening. That was the only thing that I was curious about, because I just wanted to know if Vertex said that they would, like how she had mentioned, Vertex said we would not negotiate the price of 95% in Canada. I was wondering if there was a gap put on. It maybe never even got to that level, I don't think. Okay, that was all I was curious about. Thank you so much.
Thank you.
Nice presentation, Scott. Just
Thanks,
two
Dan.
questions maybe you can clarify. Did the board conduct a cost-benefit analysis, or just can we afford the dollar amount? And the second question was, does the law apply to private payers or just state payers?
Both.
Both.
So it
Okay.
applied to anybody, so either government or private insurance.
Okay.
So it applied to both. And I don't believe a formal cost-benefit analysis was part of it. I don't know if you guys happen to know, but it was something like a 25-page report, and I did go through it in brief, but I don't recall.
So it
seeing a
wasn't like NICE or ICE or anything like
No.
that? Okay, thank you.
No. Yep. Thank you. Thank you.
Thank you so much, Dr. Sagel.
And thank you all. I realize there were others that had questions. I would encourage you to submit them through the app, and we'll share those questions during the panel discussion at the end. Our next speaker, though, is Dr. Rebecca Brown. Dr. Brown is a pediatric pulmonologist and an associate professor of pediatrics at the Vanderbilt University Medical Center, and is the co-director of the CF Center at Vanderbilt. She has served as the co-chair of the Care Model Committee, which has developed interim guidance published as position papers addressing how the model of care should be adjusted to meet the needs of people with CF in the U.S. and what changes should be made to the interdisciplinary team to support these programs. And so Dr. Brown will be speaking with us today about comprehensive care for people with CF and optimizing systems for care.
Thank you very much for this opportunity to speak today. I'm going to be talking more about the model of care and the conversations we had when we were developing the interim guidance in regards to optimizing systems of care to meet the needs of people with CF. I have no direct relationships to disclose to this presentation. As I mentioned, we're going to review the considerations that we had for the cost of routine care for people with CF and how this relates to the new model of care to meet the needs of people with CF. And then we'll also review some challenges with optimizing care for people with CF, as there's always trade-offs, and discuss the benefits and barriers to alternative methods of healthcare delivery. So as you know, the interim guidance 2 position papers were recently published. They're available on the Journal of CF website as of Wednesday. And they focused on 2 main areas of routine outpatient care delivery. So this doesn't address inpatient care or acute care, so sick visits and things like that. We focused on the model of care as well as the interdisciplinary team structure. We involved the CF community at multiple levels because we really needed to hear the CF voice when developing this guidance. And so on the committee itself, we had parents of children with CF, we had adults with CF. We had a public comment period for papers prior to submission for publication, which included feedback, a lot of feedback actually from community members. So if any of y'all participated in that, thank you very much. And then we also had an Adapting CF Care survey, which was circulated last year around the time of NACFC, which really provided us some more information about what's needed in the current landscape of CF. And so I'll have some of the results of the survey throughout this presentation. We got almost 1,300 responses, with about 590 from care team members and 680 from caregivers and people with CF. Those results are also published as of Wednesday on the Journal of CF website. I wanted to focus a little bit on some considerations and discussions we had when developing the interim guidance. First of all, we wanted to be very careful in our wording. We didn't want to accidentally affect insurance coverage if somebody needed a different level of care for their own CF. And so what we did is we maintained the model of care of 4 visits per year, and then gave special considerations and a framework for discussions with individuals with CF between themselves and their care teams to determine when we could lessen the CF frequency of care. And we did it that way instead of saying, okay, we have a baseline of 2 visits a year and you can escalate based on needs, because we were worried that may mean that insurance companies would cover 2 times a year visits, and if somebody needed more, we would no longer be covered. In addition, we recognize that people with CF and their family members are a critical component of the CF care team. And so I know a lot of people, a lot of the comments we received back is that this voice wasn't in there and we didn't use individual preference for how often they're going to come to visit. However, insurance companies can look at the words individual preference and decide that that's not medically necessary. So that's why we left that component out, but we recognize that obviously these discussions are occurring between individuals with CF and their family members, and that's where that individualization occurs. So one of the big questions is, if you're doing well and you have CF, is the cost of coming to CF clinic worth it? And so as you've already heard from the cost survey, this does not only involve copays and facility fees and whatever other charges you may have from the visit itself, but also gas or parking and vehicle upkeep, missed work, missed school. There's also even more indirect costs, such as you no longer are exempt from exams, which is a big deal for high school students. And then childcare for adults with CF, as well as siblings who have CF and then need to come to the visit without having the distraction of their siblings present. In addition, when people come to clinic, not everything is covered by insurance. We know that sometimes you have to go to a different lab or have a different lab company do your lab work, or there may not be coverage of the lab work that's recommended for CF. We have the cost of cultures, the cost of spirometry, and then not all of our interdisciplinary team members are covered. We hear this particularly related to dietitians, where insurance may not cover a dietitian evaluation, even though an annual evaluation is part of the standard of care for CF. So we asked people with CF and caregivers of people with CF, is there still value to coming to in-person visits in CF clinic? And as you can see, most people feel there's quite a bit of value with the in-person visits. In addition, we asked, how often do you want to be seen in person if you're in a typical state of health? So kind of getting at that routine outpatient care. And as you can see, most people want to be seen every 3 months or every 4 to 6 months. But we understand that as we talk about lessening the frequency of visits, there are going to be some tests that are going to be done outside of CF clinics. So we also asked, what challenges do you face when you're trying to get testing done outside of the in-person visit? And so the dark blue here is adults with CF, and the light blue is caregivers. As you can see, the top 3, reported by about a third of the people who responded to the survey, said that the results don't get sent to the care team, they are not done correctly, or there's difficulty scheduling tests. In addition, about 1/5 of people say it just takes too much time. You go to CF clinic and then you try to go and get testing outside of CF clinic, that's too time consuming. And another 1/5 just forget to get the testing done, which I think is a very human response. Life intervenes and you just forget about it altogether. In addition, we know that people are not always confident with the testing they receive outside of a CF center. You can see some are rated as higher levels of confidence, but you can even imagine, for example, height and weight may vary across the lifespan. So an adult getting a height and weight outside of CF clinic means you just stand on a scale and then report whatever height's on your driver's license. But for a wiggly toddler, we struggle with getting a height in clinic, and we're trained to do so. And so asking families to do that at home can be a little tricky. In addition, and this comes to no surprise to any of us working on a care team in a CF clinic, home spirometry and sputum and throat cultures are difficult to obtain outside of the in-person visits. And so there's still work to be done to be able to access care outside of an in-person visit and allow testing to occur in a reliable fashion. So how might cost and coverage affect people with CF? You've already heard some about medication issues. And so I wanted to bring up something that one of our adults with CF who's on our committee mentioned. We were talking about fecal elastase measurements. And I think this example really brought home for me, kind of as we move into this new era of CF care and we talk about de-escalating care in some situations, making sure that we're able to preserve the aspect of care if we have to escalate care in the future. And so Jennifer Kyle, an adult with CF, said that when I was diagnosed with cystic fibrosis at 37, I experienced severe pancreatitis and was prescribed digestive enzymes. That was 22 years ago. 2 years back, I relocated and began treatment at a new CF clinic where I had to repeat my pancreatic insufficiency test. The results showed pancreatic sufficiency, though just barely above the cutoff. Consequently, my insurance company refused to cover the costly pancreatic enzymes, despite my ongoing symptoms of pancreatic insufficiency. After enduring 2 years without the enzymes, I was hospitalized due to serious gastrointestinal problems. Eventually, I was reclassified as pancreatic insufficient and regained access to my enzymes. It's frustrating that insurance companies can determine medication access even when a doctor advocates for it, leading patients with chronic, lifelong genetic conditions to suffer more. So I want to thank Jennifer for sharing this with us, because we were all excited about the idea that people could get their fecal elastase retested and we could maybe stop enzymes. And we hadn't thought about this aspect, that if we do this and people need them, if they're in that borderline area of insufficiency, we may cause them to not have coverage. So I'm going to move on quickly to alternative methods of healthcare delivery. When we asked the community members and the interdisciplinary care team members if telemedicine should be offered, over 90% of people said, yes, please offer telemedicine. When we asked if the availability of telemedicine decreases the frequency of in-person visits that are needed, you can see the care providers were like, absolutely, let's do it. And the community members, about half of them said, okay, and half said, maybe not. And I think this shows kind of the variability that people have experienced across the country with telemedicine. So we asked people what the benefits of telehealth were that they perceived. These are more of the patient-centric benefits, and there's a lot up there, so bear with me. We have community responses and care provider responses. You can see that a lot of people feel that you can save time and you can have quick scheduling of sick visits through telemedicine, which is nice. However, when you look at the remaining responses, the interdisciplinary team members more felt that these were benefits than the community members, which just shows the difference in the experiences that the care team has compared to the people who are actually receiving care through telemedicine. The biggest change, or the biggest difference that shows up here, is the need to arrange for childcare, where as interdisciplinary team members, we think this is a big deal, and then only 27% of the community who responded to this survey felt this was a big benefit. Moving on to clinical benefits, you can see that a lot of people feel that it does reduce the infection risk and that it's valuable to see the home environment when making clinical decisions. But not as many people felt that it was important for other family members to join the appointment. And it doesn't really help to increase the number of contacts with the CF team or the transplant team. And then challenges with telemedicine. And we know that there are lots of challenges. This doesn't even bring up the issues of not being able to provide telemedicine across state lines if you don't have certain licenses. And so there's a lot we need to work on and advocate for in this area. But the top reasons or top challenges for telemedicine are not being able to get testing at the time of visit. We already talked about those challenges of even getting the testing outside of the in-person visit, and the limited physical exam. What's interesting is more care providers in the survey said that technical issues were an issue more than the community respondents. And I do wonder if this is a little bit of a bias in this survey, because we asked people to complete an electronic survey, automatically selecting for the people who probably didn't have the connection issues. But as we think about access to care and who really needs us to be able to access them out in the community, it's going to be people with limited resources, who may not be able to afford Wi-Fi, may not be able to afford, phone service, or they may live in an area where that service isn't available, like rural areas. And so we may be leaving behind some people who need us to be able to have those touch points through telemedicine as we move into this next era of CF care. So lastly, as we think about the frequency of visits and decreasing that frequency of visit, this kind of goes back to what I was just saying. We're decreasing touch points with the clinical team. And I think sometimes what we don't realize is how important it is for people to come in and just have a little, poke the head in from the social worker and make sure everything's okay. Because sometimes between visits, there may be a loss of a job or food insecurity may have developed. And so having those decreased touch points with social work and mental health coordinators, which are harder to access out in the community, may actually cause problems in the future. And then the other thing is that as we decrease what we're doing in the clinic setting or how often we're doing that, there's gonna be a trade-off because now there's gonna be a lot of time spent outside of CF clinic coordinating care. School issues, employment issues, and all those things that often are taken care of organically in the interdisciplinary clinic visit now will just be left for people to deal with outside of the clinic. And so in summary, as y'all have already heard from other people, the cost of CF care for the community is not only related to direct costs, but also to the indirect costs. And those can add up, and we as a care team may actually not be anticipating the needs as well as we thought we were, and that's why the cost survey and things like that are really helpful in determining that, but we're still missing some people who may not be responding to those surveys, and we may be leaving them behind. And as the new model of care is implemented, we will need to monitor closely for changes in insurance policies and coverage of CF care, as well as the unexpected effects of fewer in-person visits. And then telemedicine definitely has some benefits, but there are some barriers that we still need to work through. And also we need to work through some challenges of obtaining testing outside of the in-person clinic. So thank you.
Thank you. That was a wonderful presentation.
Thank you.
We do have one question online. Regarding the low community interest in telemedicine regarding childcare, were you able to assess what percentage of the sample had young children versus those without children or with school-age children?
So that's a great question. I don't think we have the granularity of data from that survey to be able to assess that, but it's certainly something to consider as we move forward into this new era of CF care where we probably are going to be doing more remote care and trying to really assess where the needs are and what stressors are driving those needs. Right, so I think that's a great question. I think one that we'll need to be answering over the next several years. The survey itself didn't ask those questions, and certainly there have been plenty of publications that have occurred since the pandemic looking at telemedicine and interdisciplinary care team, interdisciplinary team care in the telemedicine space. And so we show that we can do it. We don't show if we're doing it equivalent to in-person care. And so I think that's still an unanswered question and would be a great area of research for anybody who wants to look at it in the future.
We have another question online. Were there differences in perception of a shift to telemedicine by specialty or by clinician discipline type?
So we didn't have enough. So the interdisciplinary care team members it's all comers. And so we didn't look at it based off individual specialties. And so there wasn't, we didn't ask that question, and we don't have enough responses to power that type of analysis. I think certainly we know from experience that, for example, dietitians cannot always perform telemedicine. And, there's just different institutional policies and licensing restrictions that prevent some of that care to happen. And so that may vary across the disciplines.
All right, thank you so much, Dr. Burns.
Yeah, thank you.
All right, everyone, we had our break from medication and drug costs, but don't worry, it's back now.
So we're very fortunate to have Dr. Ben Rome speaking to us next. Dr. Rome is an assistant professor of medicine at Harvard Medical School, a primary physician, and a health policy researcher in the program on regulation, therapeutics, and law, or portal, at Brigham and Women's Hospital. His research focuses on regulation, use, and cost of prescription drugs and the resulting effects on patient access, affordability, and clinical outcomes. Dr. Rome's going to be speaking with us about the cost of cellular and gene therapy. The train is coming.
Great. Thanks so much for having me here at this meeting and as part of this symposium. I am a primary care doctor and a health policy researcher. My focus is on affordability and access to prescription drugs, and it's a real topic. Even though I don't work primarily in the world of cystic fibrosis, it's a world that intersects with so many different disease areas, and something I see and am very passionate about from my own experiences caring for patients. So I'm going to talk, in some broad terms with some sort of key points. I could probably talk about this topic of costs of treatments for hours and hours on end, but I will. I'll keep it focused on what I think are some of the most relevant points for the conversation today. My disclosure slide is here. I don't have any personal relationships, but I do have grant funding from the National Academy for State Health Policy, as well as from the states of Colorado, Oregon, and Washington related to work on prescription drug affordability boards, and also have a research grant from Elevance Health Public Policy Institute. All of those go to my institution. So just to set the stage here, sort of beyond the world of cystic fibrosis and just thinking generally about healthcare costs, right? The rising cost of prescription drugs is a huge problem in the United States. The average cost for a new drug that's coming out in the US has increased substantially in the last decade or 2 decades, by 20% a year. This is a study we published just a couple of years ago. The average cost of a drug coming out in 2008 was about $2,000 a year. Today, it's over $150,000 a year, and maybe even higher in some more recent data. So these are staggeringly high costs to absorb. Now, certainly some of this change is the result of differences in the types of drugs that are coming to market today versus those that came out 10, 15 years ago, right? We have more biologic treatments, more treatments targeting rare diseases. But nonetheless, when we adjusted for those factors in this study, there was still an 11% a year increase in costs above inflation. This is kind of capstoning with, in the last few years, several $1 million plus gene therapies. And, these treatments, since 2019 have been approved to treat a variety of rare diseases, including spinal muscular atrophy, thalassemia, sickle cell disease, and a few others. And all of them, you can see the price tags range between $2 and $4 million. This was an unthinkable cost just a few years ago. And I will, just to couch this in, terms of comparison, these are one-time costs, right, that are supposed to impart lasting, durable benefit for these patients. So that is a little different than, historically, where drugs were paid, or taken chronically over time. But nonetheless, these costs are very high and have posed a lot of, problems and conversations around how we're going to afford them. I think there's 2 fundamental questions when you think about the problems that are posed by these high prices, and not just those $1 million price tags, but the $100,000 price tags for drugs that are coming to market today. And the first question is the high price worth it? Does this drug offer a clinical benefit to patients that it's worth paying that price for? And often the quality of the data at the time that drugs are approved, particularly for these new cell and gene therapies, is quite limited to answer this question. For one, a lot of times these drugs are studied based on surrogate endpoints. That could be lab tests, biomarkers. This is facilitated by the U.S. Food and Drug Administration's accelerated approval pathway, which really allows and encourages companies to submit for these drugs early to try to get approval based on these biomarkers. But that means that we don't necessarily know at the time the drug's approved whether it improves clinical outcomes. Does the drug make patients healthier, live longer, healthier lives? Second is just short versus long-term follow-up. Even in the best case scenario, if you do know that a drug works very well, you often don't know how long that benefit is going to last. And for a treatment where the whole purpose is to treat now and impart benefit later on, you don't have that data often at the time these drugs are approved. You might have 2 or 3 years of follow-up on some patients, but certainly not the sort of 10, 15, 20 years of follow-up that you'd want to sort of make those value assessments of whether or not the drug delivers on that cost. So the solutions in terms of policy to answer this part of the equation really focus around value-based pricing. So doing a better job understanding and assessing the value of treatments when they come out, so that we can make as a healthcare system and payers can make informed decisions about which treatments we should pay for and which treatments are far overpriced relative to what we know about them. And also, outcomes-based arrangements are increasingly going to take up, particularly for these cell and gene therapies. What does this mean? This is essentially a warranty saying, look, we want to pay for this treatment, but we don't necessarily have the data. So we're going to sign a contract that essentially protects us in case the drug doesn't work as well as we expect it to. And obviously, everybody hopes that the drug will pan out to be as effective as the sort of promises are. But in the case that it's not, this sort of provides a layer of protection to us that we're not paying through the roof up front. Sort of a separate conversation from the value and whether or not the price is the right price is how we're going to afford that price. Really here we're talking about the challenge of absorbing these high costs, particularly these $1 million price tags for large one-time payments in the healthcare system. And part of this problem, as we've sort of already talked about in this symposium, is fragmentation in the insurance landscape in the US, right? Patients frequently switch insurers if they change jobs or their parent changes jobs, or they, become eligible for Medicaid and then sort of no longer eligible for Medicaid. And that limits incentives for payers to think about the idea of paying millions of dollars today for drugs that promise a long-term benefit, right? They're just financially not incentivized to think about what's going to happen to the patient 10 years in the future, because the chances are that's no longer going to be, the patient's no longer going to be on their insurance plan by the time those benefits accrue. So particularly if you think about long-term savings from lowering the cost of treatments for a curative gene therapy, that can be potentially hugely cost-saving down the road. But again, think about from the perspective of an insurance company trying to make that decision or an employer trying to make that decision, who's going to foot the bill now for those costs, for those savings later is a really challenging one. The solutions here are a little bit more logistical, right? We just need to think about better ways to amortize payments over time for these one-time treatments so that we don't put the entire burden up front, and also spreading the risk across more patients. I mean, we do not have a nationalized healthcare system in the United States to think about doing this, but some of the ways of addressing this problem are to help think about sort of maybe rethinking sort of how we do insurance for these types of treatments so that insurance, the idea of risk pooling it makes it more palatable. I just want to give the example of a non-cystic fibrosis drug, but of the example of drugs for Duchenne muscular dystrophy, because I think they pose these problems pretty well. There have been 5 genetically targeted treatments for Duchenne muscular dystrophy approved since 2016. This is a rare genetic disease in which muscle function does not work well, and it targets, it's X-linked, so it predominantly affects young boys. Each of these FDA-approved treatments was through the accelerated approval pathway that I mentioned on the prior slide. So based on not whether or not these drugs improved the muscle functioning and long-term survival of the patients, but whether they increased the muscle level of dystrophin, which was what the sort of drugs were targeting to do. And under the accelerated approval pathway, the company was supposed to conduct trials to follow up and make sure that surrogate outcome translated into real benefit for the patients. But those trials have been delayed for years. And in fact, the first clinical outcome trial we saw in this case was for the newest gene therapy, Elevidys, and the results were disappointing, much to the disappointment of the patients and advocates and everybody who really wanted these treatments to work better than we now think they probably do. Despite this story, despite these delays, despite the lack of evidence really backing these treatments, the US healthcare system has spent over $3 billion on these treatments from 2016 to 2022. And you can see in the graph, a lot of that was through public insurance programs like Medicaid and Medicare. I also want to make a comment about rare disease drug costs more generally, because I think frequently when I'm interacting with policymakers, interacting with advocates around this topic, the question comes up around, so what about orphan drugs or what about rare disease drugs and how are they different? Historically, the Orphan Drug Act from 1983 was designed by Congress to offer protections and extra incentives for companies to approve rare diseases. And ultimately that got defined as conditions that affect fewer than 200,000 Americans, which is actually quite a high bar. Today, almost half of drugs that are newly approved by the U.S. Food and Drug Administration have an Orphan Drug Act designation. So they treat one or more rare diseases as defined by the FDA. And the companies get the orphan designations before they get approval for the drug. Meanwhile, rare disease drugs are priced substantially higher than treatments for more common conditions in the United States. In one of our studies, it was about 7 times higher once you adjusted for other factors associated with the drug. And manufacturer sales, as a result, can be similar for drugs that treat rare diseases from those that treat more common conditions. This is a really nice study that I did with one of my colleagues, Sean Tu, and we just compared the 5-year sales in the first 5 years after drugs were approved for drugs that targeted solely rare conditions as designated under the Orphan Drug Act versus those that had no Orphan Drug Act designation. And the results show there was no statistical difference between the sales for those products. And so essentially what's happened is that these drugs that treat rare conditions are so high priced that ultimately the manufacturers are able to make these products lucrative. And in fact, in 2022, 19 of the 100 highest spending products in the United States were exclusively approved to treat rare diseases. And Trikafta is among this list. These products are highly profitable and are now some of the blockbuster drugs in the United States. And so I raise this to point out that if the designation is that rare disease treatments can't make money, that rare disease treatments have to be protected in some way, we're reaching a breaking point where that may no longer be the case. That in fact, these are the products that are driving healthcare spending in the US more than some of the more common treatments. And I also want to make a comment around patient assistance programs, because I know this has come up already. This is, from a policy researcher standpoint and an advocate of my patients, not a great long-term solution. This is somewhat of a vicious cycle where patients are stuck in the middle. We have drug manufacturers that are charging high prices. We have the payers sort of facing those prices and saying, what are we going to do? We're going to shift more of the cost onto the patients who use these treatments rather than us paying for them through premiums. And they know that manufacturers are going to step in and pick up patients' portion of the costs. So you have a treatment that's hundreds of thousands of dollars, 20% of that gets shifted to the patient. The manufacturer covers the 20%, knowing that they're still going to get 80% of the cost. And that 80% gets passed back to consumers in the form of higher premiums. These are real dollars, right? If you have an employer-sponsored insurance, this is real money that your employer is not paying its employees because they're spending it on healthcare coverage and on costly prescription drugs. Not all patients are going to be eligible for assistance, so there's a lot of concerns about equitable access to these programs. And ultimately, they're fragile. Manufacturers can change or cancel their patient assistance programs at any time. So just to point out that from a policy standpoint, this is not a great solution. This back and forth negotiation between manufacturers and between payers, health plans, patients are stuck in the middle. And rather than sort of taking away payers' ability to negotiate, we have to think about sort of replacing this with a process where patients are not in the middle, where doctors are not in the middle of this process of getting patients access to these treatments. So what's around on the landscape? I'm thinking about this more from a sort of big picture standpoint in terms of the policy landscape. We've already heard about some of these policies, but in process on the federal level, Medicare is starting to negotiate drug prices under the Inflation Reduction Act. The drugs that Medicare is negotiating predominantly affect older Americans because Medicare is predominantly the insurance program for older Americans in the United States. So although biologic drugs and cell and gene therapies could eventually be part of this negotiation program, it'll probably be several years before they make the list. In the meantime, states have stepped in with prescription drug affordability boards, and some of them have the ability to set upper payment limits. Again, stepping in and taking a step back to the last slide, saying, look, payers have no leverage here to negotiate prices. Maybe we ought to set an upper payment limit that will help make these drugs more affordable and potentially more accessible because patients won't be relying on the patient assistance programs. We heard about the example in Colorado where the tensions are real, right? Boards are really grappling with the complexity of this issue and how best to address it. And third, something that folks might not know about is that for many of much of the cost of these treatments is being borne by Medicaid. And state Medicaid programs have really struggled to make particularly these cell and gene therapies accessible. And so the Center for Medicare and Medicaid Services Innovation Center, or CMMI, has recently launched the Cell and Gene Therapy Access Model. This is a test where basically the government is going to negotiate with drug manufacturers outcomes-based contracts, and states will be able to opt into those contracts, essentially making these sort of value contracts more accessible to states and potentially making it so that Medicaid programs will make these medicines more accessible to people with Medicaid coverage. In terms of what's not happening yet, but where I think we need to go, we need better systematic evaluation, value assessments for new drugs in the United States. We just don't do this. Every other country that is a high-income country in the world does this type of health technology assessment. We in the US don't. There's a lot of disagreement about the best way to do these value assessments, but bottom line, we need to start doing it, right? Because we need to start differentiating between those products that really are transformative and change the lives of patients versus those that don't have the evidence. And second, we need better coordination across the fragmented insurance landscape to incentivize, what I talked about, sort of paying for long-term benefits. Now, you could ask Bernie Sanders, and he would say the solution here is Medicare for all. We are very far in this country, I think, from adopting a nationalized healthcare system. But in the meantime, I do think policymakers need to step in and figure out ways, particularly around these cell and gene therapies, to address the shortcomings of our current fragmented insurance marketplace. So I hope that that patient advocates and policy advocates can really step in and help to figure out what that's going to mean. So I'll stop there. Thanks so much for inviting me, and look forward to questions and conversation.
Thank you so much. We have time for one, maybe two questions.
Dr. Rome, thank you so much for your presentation. I hope the people in the room who think the answer is undermining prescription drug affordability boards listen to what you have to say. One of the things that you said was that we're not doing health technology assessment, but along with my friend Dr. O'Sullivan, I am part of one of the outside appraisal bodies that works with the Institute for Clinical and Economic Review here in Boston. They are doing health technology assessment, and I wonder if you think they're doing it right. I do, but I'm not an expert. You are.
Yeah, no, ICER is one of the organizations in the U.S. that has been able to produce sort of high-quality evidence ratings, and they do two things, right? First is they appraise the evidence and judge whether drugs work as well as the company might advertise them to do. And then second, doing cost effectiveness analyses, where I think there's more nuance and discussion about the right methods. So certainly we already have frameworks to do this in the United States, but unfortunately, and a lot of, I will say there's data that a lot of health plans listen to what ICER has to say. So a lot of this type of work that's being done both here in the US and internationally in terms of the academic literature around value assessment does make its way in. But again, you have thousands of health plans in the United States, and each one has to make its own judgment call of how to include that evidence. So I think the more we can centralize and standardize this process, maybe not completely, but just to provide strong, clear recommendations that will help employers who are ultimately making these decisions make better decisions is a good idea.
Thank you. In the world I want to live in, the government is doing what ICER is doing. So.
Yeah, I mean, I think that the debate of, again, I think we're really far from that in the U.S., but the government already does a lot of it, right? Medicare and Medicaid cover about half Americans. So it is already the government and private are splitting this responsibility. Yeah.
Thank you.
Yeah, thank you. And thanks for the presentation.
Sure.
Yeah, I guess one really quick question. I think like a lot of what you're talking about describes like a vast range of problems that originated ultimately at the fact that a monopoly-based pricing system will constantly translate into higher prices. And if the solutions are, negotiations at a state level or at a federal level, we are trying to reduce the price. If those are undermined in the short term, we're creating a bigger problem for the future. And even amortizing costs over time might help short term, but ultimately we're still going to have that unsustainable growth in healthcare costs in the long term, and future generations will have to pick up those bills. So I guess my question is, at what point do we start to question whether or not a system that essentially incentivizes the development of new drugs based on a monopoly pricing system is ever going to be one that gives us sustainable healthcare costs?
Yeah, no, I think it's a really good question. We have made policy decisions in the United States to basically say that we're going to give companies a monopoly period to set the price wherever they want. That's why the prices are going up, right? So we know that that's the fundamental problem. The bargain is supposed to be that at the tail end of that, after 10 to 20 years, that drugs go generic and we do get competition. I really worry with these cell and gene therapies, with biologics, with even Trikafta, which is neither, we're going to run into the problem of we may not actually see that day of generic competition as soon as we want. And an example I like to bring is HIV. The first antiretrovirals came out in the late 1980s and early 1990s. There have been substantial advances in HIV care over the last few decades. But today, the most common HIV med used came out just a few years ago, Biktarvy. It's arguably slightly better than some of the previous generations of antiretroviral treatments, but we're not going to see generic competition, for decades. And Medicaid is still paying, about $1,000 a month for HIV care. So we haven't actually seen that sort of tail end of competition. And I worry we'll see the same with cystic fibrosis and some of these other conditions. So I think instead of thinking about this like we should pay high costs now in order to have competition later, we really have to think, are we going to, or maybe there'll be new generations of treatment and we'll just kind of constantly be paying monopoly prices because we kind of move on to the next treatment. And that's great. Again, we want advances in care, but to your point, maybe we need to rethink what's happening during that monopoly period.
We have time for one more question. I would encourage you, if you have other questions, though, please enter them into the app.
Hi. I guess I'm wondering, I saw like on, one of your slides, you were like, things we could do, like challenge payers, you advocate for your patients. But I'm wondering, like, what does that really mean? Like how, you gave us a lot of great information, but I'm wondering, like, even on like a small level, what are the ways that we can go and then actually start to make a change?
Yeah, I think that's happening on the state and the federal level, right? The reason that Medicare is negotiating prices, the reason that states are stepping in and creating these prescription drug affordability boards is because they're hearing from advocacy groups and they're hearing from patients and they're hearing from the community, right? The government is responsive to the people. People wouldn't be voting, people in these legislative bodies wouldn't be voting for these if they didn't think there was a lot of underground support for them. So I think that, as to the policy community, to the patient advocate community, and the parents who are here and advocating, the answer has got to be that there isn't going to be a perfect solution today, right? In some ways, there's a little bit of like not letting perfect be the enemy of good, and that there's progress happening here. And I think the piece that I worry about is that sometimes policy solutions get nitpicked to the point of like what's the sort of going to be the potential downstream consequences, and every policy decision that we make in the US is going to have pros and cons. So it's important, and it's really important to lay those out. I'm a policy researcher, so that's what I do, is lay out pros and cons of policy. But the status quo is not a great solution either, right? That's a policy choice, to stay with the status quo. So I think recognizing that and thinking about sort of like when you're sort of deciding sort of where to advocate and where to spend resources, it's recognizing that at some point we need a change. We're going to reach a breaking point here, and policymakers are going to try a lot of different things, particularly in the states. Some may work, some may not work. But hopefully we can at least get on board with the idea that we should try something in order to move the bar and make these treatments more affordable.
Thank you.
Thank you, Dr. Rome.
Great.
All right, for our final presentation, we have a series of presenters, and I have the pleasure of introducing the first one. Marco Zampoli is Associate Professor in Pediatrics at the University of Cape Town and is the head of the Pediatric Cystic Fibrosis Clinic at the Red Cross War Memorial Children's Hospital. He established the South African CF Registry in 2018 and completed his PhD on various aspects of CF epidemiology in South Africa and Africa. His interests now focus on highlighting and eradicating global inequities in CF diagnosis and care.
Thank you very much for the introduction and for the invitation to speak. You might wonder, what does CF care, the bottom tip of Africa, have to do with the discussion today? But I hope to point out that whatever the cost of medication in the US sets the benchmark, and it has a real ripple effect for the rest of the world. So my disclosures. So this is a slide, this table looks at, it is just a quick snapshot of key outcome data at CF registries around the world with established registries. The blue indicating high income countries, includes the major registry, and at the bottom is registries from South Africa and Brazil. And if we just look at a few key outcomes, we can see that the number of children are significantly higher in Brazil and South Africa compared to the blues. The median age is much lower. The lung function in adults is lower. and as well as nutrition, and people are dying younger. I mean, this isn't news to us, and this was very clear disparities in CF outcomes, and this was in 2022, so it really reflects the pre-modulator era outcomes. We can only expect these disparities to rapidly expand with unequal access to modulators between these countries. So where are we with global access to modulators? This map is from 2023. Green countries are countries where there was access and reimbursement. The striped green countries where there's partial access agreements, and the red countries where there was no access and no reimbursement. And you don't need to be a rocket scientist to see which countries were prioritized and where to receive access and which were not. And these red countries are countries where there are sizable proportions of patients with CF who are eligible. I just want to point out that Brazil was one of the first low middle income countries to get access last year. And then below it, Argentina is an interesting country. This is a country, also middle income country. They stand out in that they produce their own generic version of Trikafta and modulators, and I'll get back to that later. So we've heard about various monopolies, and it's important to understand these principles. So I just want to touch on some of these things. A voluntary license is when an originator, a company, permits a third party to manufacture or produce a generic. They retain certain royalties, and various contracts and regions can be negotiated. And there are many, many examples. I mean, we heard the example of the HIV drugs. Virtually all HIV drugs in most of the world are under generic licenses at the moment. A compulsory license, on the hand, is when a government or a court can unilaterally override a patent and allow a third party to grant a license to a third party. And this is enshrined in the TRIPS agreement, and it can be done, and there are many examples where it has been done. However, just to point out that Vertex, and this retains the global monopoly, has no willingness to enter into voluntary license agreements, and in addition to that, they aggressively protect their patent worldwide. And we heard about, again, the HIV, and I come from a country, with South Africa, which has one of the highest HIV burdens worldwide, and I've lived through that area, and we've seen the benefits of voluntary licensing and affordable access, and you can see virtually everyone has access to treatment, and outcomes of mortality have dramatically reduced. So it's a good example. But I also want to share with you the experience as a South African, the journey that we went through to try and get access to Trikafta. And it may be unique to our setting, but I think there's a lot of lessons that could be learned for other similar countries who face similar obstacles. And one of the things was to challenge the patent. And I want to point out that a patient, that Sherry Nell is a CF patient, she single-handedly took on Vertex, filed an application for a compulsory license at her own expense. Fortunately, she received a lot of support from various organizations such as Treatment and Action Campaign, Medicine Sans Frontiers, the South African community, the CF Association, were co-applicants. And it was filed about 2 years ago, and as court cases do, they do drag on and on, but it got quite far into the process. But in the meantime, what we were to do, South Africans weren't going to sit around and wait. You heard about the generic option in Argentina, and those who had the means, who started regularly commuting to Argentina, long flights. They were only to procure the generic, which cost at the time about $3,500 a month per patient, considerably cheaper than Trikafta. And there was a WhatsApp group created, a very motivated group of individuals. They developed brochures on where to best coffee in Buenos Aires. It was quite a journey, and they would bring back their medication, and then 6 months later have to return. This is, of course, an expensive business besides the traveling costs and medication, and they had to pay out of pocket in advance, and some of it was claimed back through insurance companies. So we had to be innovative and find ways to make it work, and some of you might be aware of this, but we use a strategy of a modulator sparing strategy where we know that if you prescribe a CYP3 inhibitor like clarithromycin with Trikafta, you can reduce the dosing to twice a week. And for some patients, we had no choice because of to make the medication go further. We tried this out with all the necessary consents and approval, and the results were good. And I'm just presenting you this looking at sweat chloride. If you compare to those who did stay on 100% dose, you could reduce the dose to 25%, so twice a week. Sweat chloride response was the same. And even if I didn't present the data here, but lung function, nutrition, equally similar responses. So this was how we got by for a while for some patients. And traveling to Argentina became quite a cultural thing. And it was, but this was only a minority of patients who were able to access this. And so just on this strategy, and I think point this out because it really works. And with for a child 6 to 18 years, you only need 8 tablets, adult tablets, and one box of treatment could stretch out to 7 months. For adults, you need 16 tablets, and that's almost 4 months. And it was for many. We used the strategy, and it continued. And for some patients now, who are getting donations from wide, they source their own medication from various sources. There's a couple of patients who rely on a donation scheme, and it's certainly something to consider. And I had some conversations around. I understand this is happening quite a lot all around the world, and it's great. And I would strongly support it. But also, I want to point out that we wouldn't have got there without the strong advocacy of the CF community. And here are some pictures from the protests, which you may have heard about yesterday down the road. This very strong, dedicated CF community, backed up by good legal advice and the law. We were finally, it's a sex story, the South Africans in April this year were able to finally got access to Trikafta at a price that is far, far below anywhere else that the world is paying. So good story, but however, it comes with a catch. This was only true for those with good insurance, which is about maybe at a push half of our eligible patients. So I just want to end off with this picture. This was taken some time ago a few years ago outside our clinic, and patients who are still in our service. It is a sort of a good picture of the South African demographics, but the reality is the disparities that were perhaps not very distant for us has now come right to our clinic door. So this young lady who's 17 now, who's heterozygous, DEL508, she has good insurance, good lung function, started Trikafta in 2024. This young man who's delta homozygous, he can't afford insurance or modulators. His lung function 61, chronically pseudomonas colonized. And this young man who's homozygous for that 312O mutation, which is a class 1 mutation, most common in our black African populations, so he's not eligible for modulators. He has no insurance, he has no electricity at home, very poor lung function, and colonized with multiple infections. So small victories, but we still have large disparities to address. And so at this point, I want to just hand over to I mentioned that the community advocates who really supported our cause, who are the voices for CF communities all around the world, have been a great ally, and I think a very important part of our journey, and I want to invite them to the stage.
Hello everyone. My name's Gail Pledger. I'm a CF mum. I'm a founder of Vertex Save Us grassroots campaign group and the Right to Breathe campaign, and I work on the campaign at Just Treatment. I got involved in campaigning several years ago. In the UK, it took us nearly 4 years to get access. We were campaigning for Orkambi back then. And in that time, 200 lives were lost in the UK. And that's one of the richest countries in the world. And I think that set me up thinking there's something very wrong going on when that happens. In the end, we did manage to win our campaign, and we did that by persuading our government to consider breaking Vertex's patents. There was a lot of fear in the community. There was word that, Vertex would walk away, but we did call their bluff and we carried on, and the government publicly stated that they would break the patents if they had to. And probably unsurprisingly, Vertex came back to the table and we got a deal at a better price. After that success, we went on to form a global campaign group, and that's how I met Pratibha originally. And my role here is to support her really today, but I do want to set the context a little bit and say to you that to imagine for one moment your worst fear, and I imagine for most of you that would be to watch somebody you love, particularly your child, suffering and dying, and to be completely powerless. But I can tell you there's something worse than that, and that is to watch your child suffering and dying and know there is something that can save them and you can't access it. That is a whole different level of torture. And what's the barrier? The barrier is the price, an excessive, unjustifiable price tag, $326,000 for a drug that could be made for less than $6,000, and that is the root of the problem. Since 2020 and the start of the global campaign, I cannot even remember the number of heartbreaking conversations I've had with parents, particularly mums, I've got to say, like Pratibha, from around the world that are desperate to save their children. Although they're desperate, they're also incredible. They have strength, a drive and determination. And I've been in their shoes, and I know this power that it gives you if you're trying to save your child. There is no greater force on earth than a mother protecting a child. So what our campaign is doing is empowering these parents and mums, giving them the tools, the knowledge and a voice to fight this injustice. We have an incredible group of advocates and human rights experts, and they're giving their time freely because they want to help people with CF, and they understand what's important in life, and they want to make the world a better place. And we give huge thanks to all those people that are involved in the campaign with us. Lastly, I just want to read a message. It's actually a message from a mother called Madeline in Ecuador. This is a message that she wanted me to pass on to Vertex, but they didn't come out yesterday at our protest to take the petition. They turned our back on families yet again, but I'm going to read it here. She says, "Patrick is my son, and like all other children who suffer from this disease, he deserves to live a dignified life, away from so much daily medicine, from recurrent hospitalizations, from constant injections, to run and play freely with his little friends without having to wear a mask, with the fear of knowing that time after time his lungs are going to be colonized and bacteria and that force him to be hospitalized for 14 to 21 days. Seeing how sometimes he gets tired doing almost nothing is heartbreaking for me. Seeing how despite all the medication he takes, his little body is not healing. On the contrary, every day he needs more and more doses of medication to live. I am thankful, I am very grateful, thanks to the hospital and many doctors we have and the medical care. Because of this, my son is alive, but unfortunately many children who suffer from this disease are no longer here. And I, as a mother, do not want to lose our Patrick. Please, if there is a possibility of changing the whole way of life for a patient with cystic fibrosis, please do not deny it. We need this new generation medicine, which is already accessible to other countries. Why not to Ecuador too? Help us so that Patrick and other children with this condition can have a better quality of life. Let us not allow the light of these children who are so innocent go out, please. The fact is that Madeline will lose Patrick, and we will lose a generation of children with CF in poorer countries if Vertex don't change their ways or governments don't take steps to override the patents. On that note, I'm going to hand over to Pratibha, but I do want to say also what she has to say is very distressing and upsetting. It does talk about the death of children, but it's a reality in India. But if anybody would rather not see that presentation, obviously you could leave the room.
Thank you.
Before we get started, I do want to highlight we are running out of time. We are going to give Pratibha the full duration of the time she needs to give her presentation. If anyone does need to leave to go to another session or meeting, please be quiet as you exit, as we want to make sure we give this presentation its time.
Thank you.
A warm hello. Hello everyone, this is my second year at North American CF Conference. Last year when I came here for the first time, I was amazed by the information, guidance and support this platform provides. I felt I'm not alone, and I'm definitely not the only one working, thinking, and manifesting a life beyond cystic fibrosis. I was astonished about the studies done. I was surprised at how boxed we are sitting in India without this kind of knowledge. I went back to India with so much hope, faith, and knowledge on CF, and definitely a progressive future for our kids. This year, it gives me immense joy to stand here and present as a caregiver, parent, and a mother to my beautiful 5-year-old girl who has a brain of an 8-year-old.
Punch, only 1. 2. Punch. Now kick. 1, 2.
She's been doing karate since she was 3 years old, and this is her second belt. We introduced karate to her with the hope that it will support her lung function and help her in self-defense as well. Initially, it was hard for her to manage those punches and kicks, but now we have to really warn her not to use her karate moves at home. So most of the time, you'll see me screaming, "Do not break our bones with your karate moves." So why am I here? Obviously, I'm here because of Ivania. I want to tell you the story of CF in India through her story, and the stories of 3 other families back in India. We heard the word cystic fibrosis for the first time when my daughter was just 3 days old. High diagnosis is still a mystery for us because newborn screening is not mandatory in India. We still think it was God's ways to let us know about the thousands of children across the world who were suffering and needed a miracle. She was diagnosed in 2019, and after fighting with postpartum depression, exclusive breastfeeding, and knowledge on how to keep a CF baby healthy, we finally started wrapping our heads around CF. We learned about the modulators, and I can't tell you how painful it was to learn about the condition that is making your child sick, but finding out that there is a medicine there and which is completely out of your reach. How does that make you feel? You think it makes you feel helpless? No, it really breaks you as a mother. I did everything a mother would do, scrabbled to see how we could get her onto modulators. We were ready to move heaven and earth. We were all set to try and move to Canada to get access when the first COVID hit India in Jan 2020. My husband was admitted in ICU, and I had to send Ivania to live with her grandparents to isolate her from us. She was exclusively breastfed at that particular time, and it was horrible because a child who was just 2 years old had to sleep alone, without her mama, live alone, eat alone, and she was really devastated. COVID not only just terrified us with its consequences, but it also blocked us from reaching out to doctors across the globe who had knowledge on CF. This was a time when my quest of finding the best treatment for my daughter started, and I knew I will not leave any leaf unturned until I know how to treat it. I'm going to speak a little bit about life of a child with CF in India. We start nebulizing her at 5 o'clock in the morning with a mask on her face to attend a 9 o'clock school. CF is a very, very needy disease, and it's more needy in India. 1 hour each meal into 3 meals and 2 snacks takes up to 4 hours a day. 90 minutes of therapy takes 3 times a day takes up to 4.5 hours, increased to 5 hours on bad days, and there are many bad days. She attends 7 hours of school with commute time. She has 1 hour of play, which leaves us about 9 hours to do what all? Sleep, spend time with family, take her medicines, her personal hygiene, talking to her grandparents. There are days and weeks that she doesn't get to speak to her grandparents because she doesn't have time. A 5-year-old literally is left with only 9 hours in a day. Every night I have to apologize to her while I make her sleep that I'm sorry I can't read a book to you because you're equally exhausted like I am. So within a span of maybe a few minutes, she's off to sleep. CF child in India has to go through a lot of other issues because we don't have the support that you guys have here. Nor do we have social workers coming to support us when we have to explain the disease to our schools. I had to go to literally 25 schools to find out which is the school who is going to be ready to take on additional responsibility for a CF child because it is a lot of responsibility. As far as nutrition is concerned, as global standards, a CF child needs to consume 2,000 to 3,000 calories diet per meal into 3 to 4 times a day. But whereas in India, a middle and a lower income families only consume 2,000, 3,000 calories diet in the whole day. That's how difficult CF is in India. The current situation in India. So multiple patents have filed in India to prevent generic manufacturing. You can see one modulator has been given like 4 times for patent protection. The drug has not been registered in India, but they are holding the patent since 10 years. Oricambi was sold in India for 1 patient. It only came as 1 box in 2019, and after that, nothing. Vertex has acted to protect their monopoly, but done nothing to get these medicines into India, and nothing to save the lives of Indian CF patients. This is literally abuse of patents. India is overcoming challenges on rare diseases, but action on CF drug is still awaited. The Indian medicines for 4 rare diseases nearly cut cost treatment by 100 times. So we do have the manufacturing, we can manufacture them, but we are tied by the monopoly and the abuse of patents. Actions really speak louder than words. Vertex has been holding the patent since 10 years and not a single drug registered. They keep talking about donation programs, but in past 12 years, no one has got any aid in India. We need a permanent solution for this monopoly. Charitable donations will never be a sustainable solution to the injustice caused by Vertex monopoly. So how many people have got the drugs by Vertex? Literally 0. Over the last decade, they have sold 60 billion of their drugs in high-income countries. So much money, enough to protect their monopoly in India, but not enough for them to register their drugs so that children like mine might get access. We live in fear for life for our daughter every day. I have been living this life since 5 years, and I don't want to accept this life for my daughter for the rest of her life. I have literally forgotten at times if I'm a mother or a caregiver. I see kids thrive, I see mothers live. I see families have a social life. I see kids who are not hooked onto a machine. Then why not us? There are many mothers like me who have a similar story to say. This is a voice of Ekta. Her daughter Samaya was diagnosed at birth. And when she was 11 months old, her small intestine got stuck in the large intestine and she had severe diarrhea for 2 months. They reached out to me for help. I told them about the modulators and then they had hope. I don't want their hope to die with their daughter. She has a message for you.
Parents of cystic fibrosis children should get equal right to get the cure completely through the global and the government support of getting the modulators at nominal cost, which should be affordable, and finally with the help of all advanced payment, these disease should be cured 100%, God's grace and all of your support. The day-to-day challenges that we face, frequent hospitalization, medication management, nutritional struggles, respiratory therapy sessions, social isolation, financial burdens, emotional stress. You know, we never underestimate the power of a supportive community. Reach out of the families like ours, offer a listening ear and help spread awareness about cystic fibrosis. Together we can make a difference, I'm sure. And I'm hoping for the good future when we see our kids of other countries who have hold of these expensive modulators, and we being an Indian can't afford them or due to multiple reasons can't have them in our country for our kids. We are big time relying in the hope of modulators that in future we can dream of a day when my children who can run, play and breathe freely without the weight of cystic fibrosis holding them back.
The burden on India. Most of the undiagnosed patient burden is located in India. India has a birth rate of almost 25 million children every year, and CF children born can be as high as 12,500. India is probably the CF capital of the world, who knows? According to the news report dated 13/2/2023 with the title Cystic Fibrosis Patients Pitch for Life-Saving Drugs that are currently unavailable in India, There are around 600 identified patients of the disease, but the actual number of cases are more than 40,000. For them, these drugs are not available. Those 40,000 kids are going to die if we don't access the modulators as of now. We are literally wiping a whole generation. Our kids are suffering every day. In the past 24 months, we've lost more than 10 diagnosed kids in my CF community. Who knows how many more are there? As of now, we have close to 300 kids whose FEV levels are less than 60%. We have more than 100 children who are on full-time oxygen and more than 600 patients whose lungs are suffering every day. These are the kids whom we lost. I could only get these images because many parents are still traumatized about their loss. All these two kids are below the age of 5. They have beautiful smiles. We need the drugs today. We want our children to live their dreams. We want our children to see a better future. We want our children to also thrive and live a normal life. I'm going to tell you a story about Angad. This is Angad's story. I'm going to read out a little bit from my phone, his mother sent me in the morning. Angad was a very intelligent child. His IQ was very good. He didn't go to school because he used to keep sick all the time. He had so much knowledge about everything. Many things he knew better than me. That's what his mother said. He wanted to become a scientist. He was a great gamer. He used to pass the toughest time of his life, passing the toughest challenges in PS5. He wanted to go to America one day. But unfortunately, his dreams were dependent on a pill, which he did not get. I have a message from his mom, who did not lose hope till the last minute, but she lost her 8-year-old son, Angad, waiting.
Many children have lost their lives due to lack of medicines in India. We need your help. I lost my child. He was suffering a lot. Daily I saw him suffer for even a single breath every day. When he used to cough, he was unable to breathe. I can't express those emotions. We have seen our child suffer. I don't want other children to suffer like him, the way he suffered.
This should be a piece of history, a tragic reminder of the reality of CF families before modulators. But it is not. It's still a reality of most people with CF outside the rich world. My second story is about Abdullah. Abdullah is 21 years old and he lost his 16-year-old brother, Asadullah, just a year back. He hopes he doesn't lose his 5-year-old sister, Hafsa, who also has CF. When I met him recently to hand over a vest to him, he gave me a box of sweets and he said, "Thank you." It was a very small gesture. But he's just so desperate to help Hafsa because he couldn't help his younger brother. He doesn't want her to suffer like his brother did. We have a small message from him.
Hello, my name is Abdullah Khan, and today I'll be telling about my family. I lost my brother. If we had the access to this life-saving treatment, my brother could still be with us today. But as a middle class family, the cost of these modulators, these medicines are out of our reach. I have a 5-year-old younger sister who's now fighting the same battle with cystic fibrosis. Every day I see her how she is battling with this disease. Without the life-saving treatment, our future is uncertain. I'm asking for your support to help us access the medication she desperately needs. Today itself, we need help so that she can have the chance to live a full life, free from the limitation of this disease. Together, we can save her.
There are many more such stories of such lost or fragile hopes. But yet I'm standing here with the hope to get these drugs for my daughter. We've been fighting to turn all this hope into reality for these children. we've been working with Just Treatment and Vertex Save Us on Right to Breathe campaigns. From past 2 years to get access to medicines in our country, but despite of multiple failed attempts, we are still hopeful to access them in near future. We don't want to lose hope. Our children are our hope, and their hopes are these miraculous medicines. Action for increasing accessibility to CF drugs in India. All we can do is we can have multiple patent oppositions to prevent unjustified monopolies. Cases have been filed in Indian court challenging Vertex monopoly and seeking drugs to be made available to Indian population. Letters have been sent to the ministers to include CF in the list of rare diseases for which generic medicines will be produced in India because we can produce them. But we cannot do all this without your help. We really cannot. Sign our petition, share our social media posts. These profits are not as important as the life of CF patients. Do whatever you can to save children's life. To save the life of Samaya and Hafsa, or every CF child in India or across the world living with CF and dying without access. I was not sure of putting these last 2 slides, but I thought it's important. This was the last time Angad held his mother's hand before he left us. This was his last goodbye. She shared this with me in the morning today. This was the last time Asadullah prayed during Eid and kept his last fast. His family told him, you're not well, your oxygen is low, don't do that. But he wanted to do that. He did not know it would be his last Eid that he celebrated. Thank you. I want to come back on this stage and share my joy of such an incredible community who supported us. I want to come back here to share how incredible these drugs are and how life has really changed for my daughter and for so many kids in India. Thank you.
Just to add, we've on our website, which is righttobreathe.net, we've also got a clinician's letter that you can sign on to if you visit our website. It'd be appreciated.
All right, all. We are over time for our session. We have a few of our speakers up here. Again, thank you so much for everyone who presented. This was such important information to share, and thank you all for being here.